Hi everyone, this is Tim, your Block 2 lecture instructor, and this PowerPoint is going to be on electrolyte balances and imbalances. This is the second half of Chapter 13, so I'm starting on page 180, and it goes on to the end. I know that this PowerPoint is very long, it's about 45 slides. I tried to make this chapter, or the remaining chapter, as easy and as simple as possible. So what I've done is I've really just kind of broke down the slides into the different electrolyte imbalances, touched on what the electrolytes are, just basically an assessment, an intervention, and outcomes. So if you have any questions, let me know. All right, so let's start off with sodium. The normal sodium level is 136 to 145 MEQs per liter. It's needed for skeletal muscle contraction, nerve impulse transmission. Is extracellular fluid sodium level, which determines how much water is retained, excreted, and moved. Sodium ingested through foods and fluids, and sodium levels are balanced through the kidneys. And as the kidney PowerPoint had pointed out, the body uses aldosterone, ADH, and NP in order to actually balance that out. So remember homeostasis. Your body's trying to balance everything as much as possible. So keep that in mind when we go through the different electrolytes. So for hyponatremia, this is not enough sodium in the extracellular fluid. Water moves into the cell, causing cell swelling. It causes it to burst, and then it dies. Sodium level that is below 136 MEQs per liter is considered hyponatremia. And what can cause this is diaphoresis, diuretics such as Lasix, wound drainage, kidney disease, low salt diets, and hyperglycemia. So your assessment is going to be assessing the patient for an ultra level consciousness. They might possibly have confusion. You're also going to check for neuromuscular general weakness. You're going to test muscle strength in their arms and the legs because this is a sign of hyponatremia. For GI, it's going to be nausea, vomiting, and diarrhea, abdominal cramping, hypoactive bowel sounds in the left lower quadrant, and stools that will be frequently watery. For cardiovascular, you have hypovolemia. This is a rapid, weak, thready pulse and a decreased blood pressure, such as orthostatic hypotension, which makes sense. If you're lacking fluid, your blood pressure is going to be low, and to compensate for that, your heart rate is going to speed up. For hypervolemia, this is too much fluid, you're going to get a bounding pulse and you're going to get an increased blood pressure. So for interventions, you're going to reduce the diuretics. If your patient's on Lasix or any other type of diuretic, you're going to want to reduce those because your sodium is already low. Remember, sodium follows salt, or that doesn't make any sense. Your sodium follows water and water follows salt. So if you're giving a patient a diuretic to actually pull the fluid off, it's going to pull sodium off. It's going to decrease it even more. You could give IV therapy, which is going to be 2% to 3% saline. What you want to do throughout the day is actually watch their labs. Because you're giving them 2%, 3% saline, it's going to increase their sodium, but you want to make sure that you're not increasing it too much, or you want to make sure that the actual intervention is working. For nutrition, you're going to increase oral sodium intake. This could be, the foods your patient eats, whether it be bacon, canned foods, processed foods, meats, dairy products. But what you want to restrict is the oral fluid intake, and that's because the more fluid that they ingest, the more their kidneys are going to process, the more they're going to urinate. The more they urinate, the more the sodium follows. So you're not really doing anything by allowing them to drink a lot of fluids. So for hypernatremia, this is a sodium level over 145 MEQs per liter. Water moves from the cells to the extracellular fluid. This can cause irritability and an over-respondence of stimuli. So for your assessment, it's going to be the nervous system. They may have a poor attention span, a decrease in cognitive function. Your patient may be agitated or confused. It possibly could be manic, and this could lead to seizures. So for your assessment, you're going to assess their skeletal muscle changes. This could be muscle twitching, irregular muscle contractions, assesses your assessment of grips, pulls of the arms and legs is also important because of the fact that with hyponatremia, they're very weak, and with hyper, they're actually very, I wouldn't say very strong, but you can see a big difference in the strength between the two. So for cardiovascular, you're going to assess the heart rate, blood pressure, and pulses. Again, water follows salt, salt follows water. So if you have hypernatremia, you have too much salt, you're going to get an increase in heart rate and blood pressure and pulses because of the fluid overload. So for interventions, you're going to do drug therapy. This will be half normal saline, which has it says it has a higher concentration of sodium, but it's not in the sense of if someone has high sodium, you don't want to give them more, but the half normal saline is actually going to help your kidneys flush it out and actually lower the concentration. With nutrition, you're going to watch their diet. You want them to have a low sodium diet because, again, sodium follows water and water follows sodium. So if you're eating foods that are high in sodium, like the bacons and the processed foods and the canned foods, it's just going to cause more of a fluid overload and bring more sodium into the vascular system. So for potassium, let me grab my notes real quick. So for potassium, the level is 3.5 to 5.0 MEQs per liter. This is critical for excitable tissues to depolarize and generate action potentials. This is really important for the heart. Potassium also regulates protein synthesis. It regulates glucose use and storage. Potassium is extracellular fluid and intercellular fluid and is controlled by the sodium-potassium pump. So just like with sodium water, they follow each other. Sodium and potassium also follow each other. With potassium levels, they are controlled by the kidneys. So if you're having kidney issues or kidney damage, your potassium levels tend to be higher. So for potassium, it can be found in meat, fish, fruits, and vegetables. Pretty much potassium can be really found anywhere. So keep that in mind whether or not your patient is hypo or hyperkalemic. So for hypokalemia, potassium level is below 3.5 MEQs per liter. Causes could be diuretics. It could be digitalis, which is a cardiac medication. It could be low because of vomiting and diarrhea, NG tube suctioning, wound drainage, kidney disease. If your patient's not eating or drinking anything, possibly having too much insulin can also lower potassium. Patients who are hyperglycemic, we will give them insulin to lower the blood sugars, but the insulin actually drives the potassium back into the cell, so it lowers their potassium. And IV fluids can also cause hypokalemia. So your assessment is going to be based on age. Kidney function decreases as we get older. Also, as we get older, we tend to take more drugs. So they could be diuretics, corticosteroids, beta-adrenergics, or digoxin. With respiratory, potassium is needed for muscle contraction. Low potassium may result in shallow respirations. So with breathing, it's controlled by your intercostal muscles, and muscles do better with a balanced amount of potassium. So if you're very low in potassium, your intercostal muscles may not be as strong, so your breathing may not be as efficient. For musculoskeletal, potassium is needed for strength, so you're going to assess for pushes, pulls, and grips. And you're also going to assess your patient to determine whether or not they're strong enough to do their normal ADLs. So for cardiovascular, the heart is a muscle. You're going to assess their pulses, their heart rate, their blood pressure, and you're also going to assess for EKG changes. Again, the heart is a muscle, so if you don't have enough potassium, it tends to make your muscle weaker. This could potentially not allow your heart to be as efficient, and it can cause dysrhythmias. So for neurologic, you're going to assess the altered level of consciousness. You're going to find out and assess whether or not they're irritable, they have anxiety, lethargy, or coma. For intestinal changes, you'll see nausea and vomiting, and hypoactive bowel sounds, and possibly constipation. So for interventions, drug therapy could be giving your patient potassium. You either could do this intravenously, which is 10 MEQs per hour. Any more than that can cause dysrhythmias, or you could give your body too much potassium, too much at one time is not a good thing. You can also do it by PO. You can do this either 20 MEQs or 40 MEQs. And you also could do this through nutrition. You're going to assess your patient's ability to actually chew and swallow. Find out whether or not they're able to ingest not only the PO medication that you gave them, but whether or not they're able to actually eat the fruits and vegetables and the meats and things that are high in potassium. Have the lab come and redraw every couple hours to make sure that the actual intervention of giving them potassium is actually working, and to make sure that they don't go from being low to extremely high. Diuretics decrease potassium, so giving your patient Lasix or any other type of diuretic is not going to be beneficial. So see if the patient can be switched to a potassium-sparing diuretic. You're also going to assess for altered level of consciousness, weakness, and prevent them from having falls, because this is a big safety issue, especially with being weak. For respiratory, you're going to assess the rate, the depth, and the O2. So you'll make sure that, like I said, based on them being low, you want to make sure that their muscles are working correctly and they're actually able to breathe and oxygenate themselves well. Checking for nail beds, you're looking for cap refill. So for hyperkalemia, which is too much potassium, this is a potassium level that's higher than 5.0. And I'm going to catch up on my notes. So common causes of hyperkalemia is ingesting too much potassium. This could be food or medication, and this is also could possibly be kidney failure, kidney damage. Again, the kidneys will process the fluid, and it actually balances all your electrolytes, and if the kidneys aren't functioning correctly, then it may just hold on to that potassium. Potassium sparing diuretics, they do spare the potassium, so if your kidneys aren't functioning and they're also taking a diuretic that's keeping all this potassium, then it's just circulating more and it causes an increase. So your assessment is going to be kidney function. You're going to look at BUN, creatinine. You're going to make sure that they're actually working well, make sure that the input is actually coming out. You're going to assess cardiovascular. You're going to look for bradycardia, hypotension, and EKG changes. EKG changes could be peaked T waves, prolonged QRS complexes, and possibly asystole, which is death. I have not had a patient, but there are patients who have passed away from an overabundance of potassium. The peaked T waves, prolonged QRS complexes, we'll get into that when it gets closer to cardiac. You're also going to do an assessment on neuromuscular. You'll find that they will possibly have a tingling, burning sensation in their hands and feet, which is where you'll check first. And then when potassium levels get extremely high, that's where it causes paralysis, which is a weakening of all the muscles. And remember, cardiac is a muscle, or the heart is a muscle. And remember, the intercostal muscles is what helps control the breathing. So if paralysis sets in, that's where you eventually get the asystole. Intestinal changes is going to be an increased motility. You'll have diarrhea, spastic colon, hyperactive bowel sounds, and your labs are actually going to show an increase in potassium. Medication can be given to actually reduce the potassium, and you're going to give the medication and recheck labs to make sure that you're not bringing it too far down and causing hypokalemia. Other interventions is going to be monitor the heart. You're going to put them on a cardiac monitor, make sure that they're actually that the rhythms are working and doing what they're supposed to. You're also going to prevent your patient from falls due to muscle weakness. You also monitor the patient's response to the therapy. Is it actually working? Other interventions is actually administering drugs. You can give diuretics to lower the potassium level through the kidneys. You can give K-oxalate, which is a medication that you give orally, which causes severe diarrhea, which will pull the potassium with it. They also could do dialysis in extreme emergencies. They also can give insulin, because remember I told you patients who are hyperglycemic, you give them insulin, but that insulin will drive the potassium back into the cell. So giving them insulin can also also lower their potassium level. You can also give IV fluids. Giving them IV fluids will give them not so much fluid overload, but it causes them to, for their kidneys to process it more and urinate. And the more they urinate, the more potassium gets excreted. You're also going to do a health teaching, which is on page 188 on 13-8. Let's see here. 188. All right, let's see here. 13-8, patient safety and family education preparing for self-management. I think I actually chose this. I don't want you to memorize every food, but I just really want you to kind of pay attention to the amount of different foods that actually can increase the potassium levels. So sometimes you really can have patients that you just assess and find out how well they're eating, and you can suggest certain things which will actually increase their levels. Also, if you have patients who are too high, then you can also suggest fruits and vegetables and meats and cheeses and foods that they should kind of limit themselves on to make sure that they're not getting any worse. So for the next electrolyte, we have calcium. And let's see here in my notes. All right, so for calcium, normal range is 9.0 to 10.5 milligrams per deciliter. Calcium is needed to maintain bone strength and density. It's also needed for skeletal and cardiac muscle contraction, and it controls nerve impulses and blood clotting. Calcium enters the body from food and absorbed through the intestinal tract. So this will be dairy products, it will be supplements, and vitamin D. So for hypocalcemia, this is not enough calcium, and it falls below 9.0 milligrams per deciliter. Common causes can be inadequate oral intake, they're not actually consuming enough, or they're lactose intolerant, so they're not able to actually consume dairy products. Again, the way your body actually absorbs calcium is through the actual intestinal tract. So if they're having intestinal diseases, then they're not able to actually absorb it. I mean, they can consume as much as they want, but if it's not being absorbed because of intestinal problems, then it's not going to do any good. Kidney disease is also a major player in the common cause for hypocalcemia. Diarrhea based on the fluid loss, you're probably pulling calcium with it, and also wound drainage can cause hypocalcemia. So your assessment, you're going to inquire about nutritional history. Is your patient actually able to eat and drink, and are they eating well, and have them define what eating well is. 3 meals a day, balanced diet. Also, another thing you're going to assess is orthopedic surgeries. Patients, especially elderly patients who have broken bones, the calcium is going straight to that to fix it, but it's not necessarily in the bloodstream. Endocrine disturbances can also be a reason for hypocalcemia, thyroid surgery, because it possibly could do some damage to the parathyroid. Also, radiation to the neck and chest can cause it based on the parathyroid gland. For neuromuscular, you're going to assess for tingling and numbness of the hands, feet, lips, nose, and ears. You're also going to do the Trousseau's and the Hypophosphatemia sign. You're going to assess for muscle twitching, painful cramps, and spasms. So for cardiovascular, their heart will have a slow or fast heart rate. It will possibly have low blood pressure. EKG changes will be prolonged ST interval and a prolonged QT interval. And for intestinals, you'll see hyperactive bowel sounds. And for skeletal, it'll be bone loss and loss of height. And that's over a process of years, not actually overnight. So for drug therapy, you're going to replace the calcium. This actually could be through IV therapy. You could do nutritional therapy, which is actually replacing their calcium with a natural balanced diet. And also another intervention is going to be injury prevention and seizure precautions, which is found on page 190. And it is under interventions. I want you to read that real quick. As far as I think the biggest symptom you'll find with hypocalcemia is the possibility of seizures, and I want you to follow the interventions based on what to do for like seizure precautions and safety and what to look for. So for hypercalcemia, calcium level is above 10.5 milligrams per deciliter. Common causes could be an extreme intake of calcium or vitamin D, kidney failure, or diuretics. With extreme intake of calcium or vitamin D, I think this is probably more of supplements and eating excessive amounts of dairy products and stuff. Kidney failure, again, as we've mentioned pretty much so far with all the electrolytes and even with the kidney PowerPoint, the kidneys play just such a major role in the fluid and the balance of your body. The biggest problem with hypercalcemia is blood clotting. It actually causes the blood to clot too much too fast, and especially in the legs and the pelvis. So your assessment is going to be cardiovascular, slow heart rate. Neuromuscular is going to be decreased deep tendon reflexes, and intestinal is going to be decreased peristalsis and constipation and nausea and vomiting. Interventions is going to be IV therapy, which could be half normal saline. It could be diuretics. They can do dialysis in extreme cases. You'll put them on a cardiac monitor to make sure they're not having any type of cardiac dysrhythmias, and you're going to also look for a decreased cardiac output. And as we go into cardiac, you'll hear the calcium channel blocker medications, and like I said, we'll get into that further on. So for phosphate, this is a normal level of 3.5 to 4.5 milligrams per deciliter. It's needed to activate vitamins and enzymes. It's also needed for ATP for energy supplies, assisting in cell growth and metabolism. It also helps with acid-base balance. And it also helps with calcium homeostasis. Calcium and phosphorus follow each other. So just like with water and salt and water and potassium and salt, those follow each other. Well, calcium and phosphorus follow each other. All right, so for hypophosphatemia, phosphate level falls below 3.0 milligrams per deciliter. These reasons could be malnutrition and starvation. It could be antacids. Aluminum and magnesium-based antacids tend to cause phosphorus levels to drop. Hypercalcemia will cause hypophosphatemia. This could also be based on kidney failure. It could also be based on uncontrolled diabetes and alcohol abuse. So your assessment is going to be for cardiac, decreased cardiac output, slow peripheral pulses, which kind of makes sense because if your heart is not beating efficiently, then you won't have a great peripheral pulse. For musculoskeletal, it's weak muscles, which leads to respiratory failure and muscle breakdown. Your assessment for this will also be central nervous system, which is seizures and comas. So again, definitely look at page 190 for the seizure precautions. So for interventions, you're going to obviously give them phosphate, and for nutrition, on page 192, 13-9, let's see what reason I chose this. Let's see here, patient and family education, preparing for self-management. So for nutritional management of hypophosphatemia, you will avoid milk, cheese, yogurt, collard greens, and rhubarb. Again, because calcium levels go up, phosphate goes down. But they can eat fish, beef, chicken, pork, organ meats, nuts, and whole grain breads and cereals. So it's pretty simple. So for hyperphosphatemia, level is above 4.5 milligrams per deciliter. This is a rare problem directly linked to too much phosphorus. Usually too much phos equals too much calcium. So fix the hypocalcemia symptoms and you'll fix the hyperphosphatemia. So for magnesium, normal range is 1.3 to 2.1 milliequivalents per liter. This is needed for skeletal muscle contraction, and remember the heart is a muscle. It's also needed for carbohydrate metabolism, ATP, vitamin activation and cell growth, and it's also used for blood clotting. Regulation is through the kidneys and the intestines. So for hypomagnesemia, magnesium level falls below 1.3 milliequivalents per liter. Causes can be malnutrition, starvation, intestinal problems, diuretics, and ethanol consumption. So symptoms for neuromuscular, you're going to have deep tendon reflexes. You'll have numbness and tingling, painful muscle contractions. You'll have positive Trousseau's and Chvosik sign. You'll have weakness in the muscles. You'll have tetany and seizures. And you also have central nervous system problems, which will be depression, psychosis, and confusion. Intervention is going to be drugs. You either can give this orally or through IV. For IV, it's going to be 2 to 4 grams, but don't forget to recheck your labs because, again, you're going to do an intervention and you're going to recheck them just to make sure the intervention worked. So nutrition, it's really going to be just a better diet. So for hypermagnesemia, level is above 2.1 milliequivalents per liter. Your assessment is going to be cardiac, a decreased heart rate and blood pressure. EKG is going to be a prolonged PR interval and a wide QRS complex. Again, we'll go over that when we get to cardiac. So for central nervous system, it's going to be voluntary and skeletal muscles are weak. And don't forget the heart and lungs are muscles. Sort of interventions, you're going to do drugs. You could do diuretics to actually bring that level down, and you can also give IV calcium. Nutrition, obviously a better diet. And that's actually pretty much it. It's actually faster than I thought, 25 minutes. So if you have any questions, let me know. I suggest, as I mentioned before, definitely memorize your labs. Find a commonality between the hyper and hypo for the electrolyte imbalances. And I think a lot of it really makes sense. If the electrolyte itself causes muscle issues, then remember your heart and your lungs. If it is absorbed through intestines and you have intestinal problems, then, so like I said, just kind of keep it simple. Find a commonality as far as what each electrolyte does and what possibly could happen, and just really how you're going to fix it. And the only thing I can really tell you is that keep checking labs. That's the best way you're able to determine whether or not medications and your interventions are working. If your magnesium's too low and you give magnesium and now it's too high, then you know you did too much. If you gave just enough and it's right where it needs to be, then it worked. So, all right, so let me know if you have any questions, and thank you very much.